Well, hello, my friends, and welcome to another special guest episode. I am oddly just really excited today to talk about our subject with our special guest, Dr. Christy Gibson, uh, whose book I have right here, The Modern Trauma Toolkit. So we're gonna talk all about it. But before we dive in and geek out, Christy, welcome to the show, and please introduce yourself.
I'm happy to. So I'm Christy Gibson. I'm a family physician in Calgary, Canada. So that's the west side, just not far from the Rocky Mountain. I can sometimes see them from my workplace. I have been a family physician in many different capacities. So I did hospitalist, community-based family practice, and I work now mostly as a trauma therapist in refugee health and adult addiction. So I've had many hats over my career. I ran our health equity residency. So I have a master's in medical education, and I have a brand new doctorate in transdisciplinary study. So I've been a huge proponent of social innovation and systems thinking to solve complex challenges in medicine.
Really the quintessential family medicine person who just loves a little bit of everything, right?
Yes. The generalist who can't stop learning. Yeah, that's me.
Oh, yes, yes. I hear you. I hear you. Well, tell us a little bit. So I always have people, who come on the show, give us a little bit of your story as it relates to experiences with burnout, overwhelm, and of course, you're coming on because we're going to have some discussions about trauma as well. Um, yeah, tell us a little bit about your story.
I would love to. And you know what's so interesting, Megan, is I haven't talked about this particular angle yet. So it's interesting to share it and feel a bit vulnerable. I'm just kind of noticing there's some bubbling in my guts. Like, are you going to
Yeah.
do this?
Yeah.
So yeah, I started work as a hospitalist fresh out of residency to pay off my loans. I just thought this would be such a nice way to make a better income and continue to learn internal medicine because
Mhm.
our family med residency in Canada is only 2 years, and I did not feel
Mhm.
sufficiently ready. So I jumped into hospitals thinking, well, I'll have all these colleagues and these specialists around that I can continue to learn from, which was 100% true. But the kicker of the whole model where I worked was we generally worked 80 to 100 hours a week.
Yeah.
And when you're young and scrappy, you can get away with that. And initially, I started working 1 week in the hospital and 3 weeks in community doing locums. And that was a reasonable balance. Although, first 2 years, I still worked all but one weekend per month.
Yeah, yeah. And you're like, "That's fine. I was just a resident. This is
It's fine.
normal, right?"
It's fine. Um, so then I moved to 2 weeks and 2 weeks model, thinking, well, at least maybe I'll get more weekends free. And eventually I just quit doing family practice locums and worked in the hospital. And it was a really lovely model because I would work 2 weeks on and 2 weeks off.
Mhm.
Um, and what I didn't recognize was those 2 weeks on were so on and the toll
Yeah.
to my mental and physical health it was taking. And I started to get really sick in my night shifts because we would work like multiple hours, especially on a ward night.
Yeah.
Like we could be there 30 hours.
Mhm.
And so around like 2, 3, 4 in the morning, I started to get really ill. And um, I did a 24-hour blood pressure monitor and I topped out at about 220 on 120,
Wow.
um, which is crazy because, I could have just had a stroke in the emerge department where I was trying to admit patients.
Yeah.
Um, and I knew something was wrong, but I didn't understand just how much like stress hormones were circulating in my system until my family doctor proposed because we did like a whole secondary workup because I was in my early 30s at this point.
Yeah.
Well, okay, maybe late 30s. Anyway, it was way too young for me to be
Too
like,
young. You were too young to have that.
so they're like looking for adrenal tumors and like, renal artery stenosis and all these possible primary causes of hypertension. And they found nothing. Well,
Mhm.
they didn't find nothing, but like nothing that turned out to be consequential. Um, and then my family doctor had the idea of doing a 24-hour monitor on a day off. And it
Mhm.
was insane. Like my blood pressure dropped in half. I had a totally normal blood pressure on a day off. So I'm just really, really sensitive to like cortisol and adrenaline and all the stuff that was keeping me up for these
Yeah.
like long and super stressful shifts. And it was then that I realized like I enjoy this job, but it's killing me.
Yeah.
And I had to figure out a new plan. So, I
Yeah.
mean, I did enjoy the job. I would still enjoy the job. I loved the acuity, the constant learning, interesting patients. I worked at a lovely community hospital. And so I tried to get like some of the elements into my family practice when I did briefly work as a community-based family doc. But to be honest, I think I burned out from that too because it was during the pandemic. We were getting so many places of resistance about all
Yeah.
kinds of things.
Yeah.
My family practice was really high level of complex chronic disease because of a history of trauma,
Hmm.
and the demands were just really high, both physically and psychologically. So um, I wouldn't say it was as burned out as from the hospital, but I knew I needed to make a change.
Hmm.
So yeah, there's been two major transitions where burnout played a huge factor.
Yeah. Well, and they are very different environments and very different stressors, even though, the disease processes are largely the same, right? But yeah, the resources that are available, the acuity, the paging, like all of those things are very different.
Yeah,
But I think it's so important what you said of I realized that this job was very visibly harmful to me, right? Because we sort of brush that aside, right? We talk about sleep deprivation and we talk about um, just the sort of random consequent, like, oh, we don't get to go to the bathroom, we don't get to eat, we don't get to take care of ourselves in those ways. But it is not normal to be able to push your blood pressure that high, right? 220 over 120. Like there are physiologic things going on in your body that no one would argue is a good thing or a reasonable thing, even,
yeah.
right? Um, and yet, how often would people sort of push through that same kind of story, right? Because I bet you didn't stop working.
I didn't know. It was probably 2 years before I finally stopped. I mean, I needed an exit strategy, but I still
Yeah.
should have listened to my body a little quicker.
Right.
Yeah,
Right.
I held the job for 16 years, which
Yeah.
is a really
Yeah.
long time to put yourself at risk in that way.
It is, right? Because yes, something could have happened at any point along that could have been quite devastating. And of course you don't know, and thankfully it didn't. But our bodies are not meant to do that. Just like they're not meant to work 80 hours. They're not meant to be up for 30 hours at a time on a regular basis. Like that's not actually what our human bodies are supposed to do, even though the system has been set up in this way where that ends up being normal for us.
And I think you've hit the nail on the head, Megan, around that question of what's normalized. And I think physicians in particular are really good at disconnecting from our human needs. So I would, as a trauma therapist, call this a dissociation. So
Yeah.
we learn to ignore the interoceptive signals telling us like, hey, I'm hungry. Hey, I need some sleep. This is not good. And we just learn to suppress those signals. So
Yeah.
like as I know so many days on the job where I would be like, I'm pretty sure I'm finishing my day in renal failure. Like, I don't remember the last time I drank water.
Right. Right. Well, that would be inconvenient to drink water because A, you'd have to stop, which meant, you were making somebody else wait, and B, eventually you'd have to pee, and that would
Right?
make somebody else
That would
wait.
be terrible. No time for that.
Oh, well, let's explore that a little bit more because, I'm somebody who, I do identify with the diagnosis of PTSD. And for me, it was very much little t traumas experienced over and over again,
Mm,
in the practice of medicine. And as you and I were talking just before we started recording, I think that is absolutely under-recognized and underappreciated. And we didn't learn about I don't know, kind of what your experience was during training. I didn't learn anything about PTSD except, the usual like veterans, maybe, victims of
Yeah.
sexual assault. Um, and prazosin was good for them. Like that's the extent of what I learned,
Yeah,
right?
totally.
And I had a hard time when I started seeing patients more and more independently, identifying what was going on with my patients when they were, acting very scared, very, very upset, just seeming really very irrational, especially, for example, around pap smears and pelvic exams, right? I couldn't identify what was going on here.
Yeah.
That this was such a trigger point for people. And I remember asking attendings to talk, to like, yeah, I don't know what's going on, but this seems to be difficult. And they wouldn't name it either.
Hmm.
Um, so I think we weren't properly trained to identify it in other people, and yet it's so pervasive in the exam room.
Oh, for
But
sure.
but we
I have
also,
so many patients triggered by,
yeah,
disrobing or, um, yeah, as you mentioned, pelvic exam. Dental exams are super hard.
mm,
There's so many things that I now recognize because I'm now trauma informed, but we certainly
yeah,
aren't trained to be trauma informed, both for ourselves and our physical bodies and our vicarious traumas,
yeah,
and certainly not related to patient care. And this is maybe another layer of depth, but so often we blame the patients who are stuck in those fight, flight, and freeze responses. So we'll
mhm,
call a freeze response non-compliant. Well, you
right.
didn't show up to your appointment. You didn't adhere to the treatment plan.
You're
Um,
not saying any words. You're not telling me what I need to know.
yeah.
Yeah.
And fight and flight will show up as irritability, and of course, that's hard on us.
Yeah.
Um, but we're so quick to kind of blame the person and not get curious about, well, what happened to them. And um, I don't think that's inherent in us as human beings. I think it's very much like a social conditioning that happens through medical schools. You're looking for like a diagnosis. And
Yeah.
interestingly, complex trauma is still not in the DSM. And I learned literally zero about it.
Yeah.
And it turns out every single one of my patients have it because I work in refugee health, adult addictions, and in people who have high ACE scores, which I wouldn't have even known how to name
Right.
10 years ago.
Right. And I think at least, this is another area in medicine, right, where patients don't fit in the box of a 15 or 20-minute visit, or, they're not tidy when they've experienced trauma and it's manifesting in the exam room,
Yeah.
because they're not organized yet. They're not compliant. They're not sort of going along with the, I don't know, the scripted dynamic of patient physician, interaction. Um,
Well, and you hit another nail on the head, Megan, when you said that they're not able to verbalize, because one of the
right.
things I didn't understand before I started to really research trauma, and certainly well before I wrote the book, was just how often when your amygdalas are firing and they're kind of taking over, they produce reflex responses. And so our thinking brain doesn't even get involved. And when they've done
Mhm.
functional neuroimaging, you can actually see, like, once your amygdalas start firing, all the connections to the cortex drop off. So our patients
Mhm.
literally can't think.
Yeah.
And that is such an eye opener to realize that it makes sense that they are nonverbal or unable to express. It makes sense that they can't remember anything or focus or concentrate, all these things. Um, a lot of brain fog can relate to complex trauma and their traumatic responses to other illness experiences, which is so, you know, ill defined and not often identified.
Yes. Yes. And, yes, often won't be named. And sometimes even when there's opportunities, even when there's a safe space, to kind of open that door, open that conversation, of
Yeah.
course, we may not feel equipped to do so because we are often not trauma informed. And of course, we can't force that safety on someone, right? We can act in a manner that demonstrates, and communicates safety to the best of our ability, but we can't actually help that human nervous system in front of us to feel safe.
Yes, and um, I feel quite differently now that I have the skill set that I do.
Mhm.
I do feel that there's something called co-regulation, and it's basically attuning your nervous system within your window of tolerance. And there's a much better chance that the person in the room with you will also be able to reach it. So I used to go into exam rooms in my sympathetic nervous system, like
Mm,
racing from room to room, not calming my own nervous system down, not quite hand on the doorknob, but just like we've got this time constraint. And I'm so much more deliberate now about how I show up, and I'm attentive to my vocal prosody, um, my body language and facial expressions, and the way that I am cueing for safety. And there's a
mm,
much better chance now that people will meet me there.
yeah.
Like I have some folks that are really, really caught up in that fight and flight pattern. And by the end of a session with me, they will have a completely different tone of voice and just be in a different nervous system. Like you can see the
Yeah.
parasympathetic kick in. Um,
Mm,
so I do think that there are a lot of skills we can learn. And it's one of the reasons why I wrote the Modern Trauma Toolkit. I mean, it was intended for patients because I wrote it for my patients so it would be a safe and accessible resource.
mhm.
But I'm trying to get more clinicians to read it because
Yeah.
we didn't learn this stuff.
Right.
And there is actually so much we can do. So the whole
Yeah.
back half of it is all solution focused. And
Yeah.
you can do really quick interventions because people will always clap back at me and say, oh, well, I've got like a 10-minute visit. Right. You could spend 40 seconds teaching them a somatic skill.
Yeah.
And that would be well worth your time because next time they see you, they're probably not going to be in the middle of a panic attack.
Right.
And you maybe can get that pelvic exam done.
Right. Right. Well, and talk a little bit about, kind of the other person in the room, right? The physician themselves, right? Because that's another aspect of trauma that we don't talk enough about, of how many physicians are traumatized in various ways by their work. And of course, that might, be secondary trauma from, sort of being witness to other people, experiencing trauma, but it may also be a sense of lack of control and being stuck in a situation that feels unsafe to their nervous system. How do you see that show up? Because like I said, I think that's something that we don't talk enough about, and it's certainly something I see a lot in my clients.
Oh, 100%. So you mentioned kind of two things. One would be like the vicarious trauma of being the witness, and we often elicit the suffering of our patients, whether it's
Yeah.
physical pain or other, intolerable distress, or we're eliciting their emotional history, their, uh, you know, um, childhood adverse experiences. A lot of people will do an ACE score.
Mhm.
I'm pretty hesitant to do that for a number of reasons, but there are so many ways that we can elicit that story. And a lot of what I do as a trauma therapist is establish safety for months. And then I actually process trauma without them having to ever say a word about it.
Mhm.
So I have way less vicarious trauma now that I'm informed about the different ways to approach it.
Yeah.
I mean, I have witnessed death, like I would guess 1,000 times between the hospital and then I've been
Mhm.
a practitioner of medical assisted death.
Mhm.
And those deaths, like those are quite calm and comfortable, and they're surrounded by family. They're usually
Yeah.
quite beautiful, but the story of why they're suffering so much that they want an assisted death was something that I didn't realize was impacting me.
Mm. Mhm.
Until I had a really good psychedelic journey session, and I was like, "Oh, there's a lot in here related to that."
Yeah.
Um, so when you look at the definition of PTSD, one of the possible criteria of the event that can cause it is witnessing trauma. And we do that. I mean, most of us, depends on your discipline a little bit, your
Yeah.
specialty. Like if you're a pathologist, you might see a little less of it, but a lot of us have these experiences almost daily. And in a hospital-based practice, it might be room to room to room, just a variety of trauma, like a whole
Yeah.
smorgasbord.
Yeah.
Um, so yeah, I think both the vicarious trauma and the ways that we are harmed by the profession and its expectations, the casual racism, if you are a racialized physician, the gender gap in leadership and pay and respect and all other
Yeah.
quantifiable metrics for women physicians and anyone else with other social identities. And then the dehumanization that's almost a necessary factor of training. And it's been this way for so long that there's this orthodoxy that this is how it's done.
Right.
And so few people are willing to jump outside of this paradigm and say, could we do it differently in a way that doesn't harm us or patients? And I know that that's possible.
Yeah.
And some
And then consequently, can we practice that way on the other side? Right? Because although we think of it as a finite thing of training, I think most of us in practice would say, oh, no. We don't become more human after we graduate from residency, right? After we're out working as an attending.
Yeah.
We carry that with us. We carry that I'm not allowed to be a human and not allowed to have needs often into the world. And, the business of medicine often perpetuates that idea of like, well, yeah, you're the non-human entity here, right? You're the professional. You don't
Well,
have needs.
if you look at what causes trauma, there's kind of the landscape. So part of our landscape is a little bit powerless because we're told what to do by insurance, by, kind of these constraints about what's available and what algorithm we're supposed to be following. We often are quite isolated. Like, I mean, even though many of us have group practices or we're working in multidisciplinary teams, the responsibility is ultimately on our shoulders. Like, we are the ones making the decisions and we have to be accountable for those. And that's a very isolating position. And because we make life or death decisions by the hour, that's so unique.
Yeah.
So, like, when you look at the elements that can create traumatic experiences in our body, we've signed up for it without really knowing.
Unknowingly signed up for it.
Yeah.
Yeah. And I think, and give me your thoughts on this as well. Like, I think that this is a very real thing that is even more marginalized than conversations around burnout, which, certainly have emerged much more clearly, I'd say over the last 10 years, right? I don't remember anyone using the word burnout, probably till, I don't know, 12 to 15 years ago, really sort of started to sort of come into the conversation. But I certainly don't hear people generally speaking about the trauma that we experience. Maybe conversations about witnessing, extreme damage to people's bodies, right, in the emergency room or, surgery context or something like that. But not really.
Yeah.
Not really diving into the impact and not really speaking to that lack of psychological safety, that exists so much in the landscape of outpatient medicine where, we're constantly experiencing moral injury at not having a whole lot of control or not having a whole lot of resources or support to ease the suffering of the humans in front of us.
Well, and there's another misnomer too. I love how you said moral injury because that's such a huge component of it. But people talk about compassion fatigue, whereas it's really like an empathy fatigue because we are kind of ending up walking in people's shoes, but our journey is really meant to be alongside, and walking in their shoes really does harm us. So I've had to be actually more boundaried in as much as I'm still willing to show love to my patients. I also have to be more boundaried because protecting myself first is so key. And I don't think I'd let myself do that sufficiently. So I love how you mentioned psychological safety. One of the many things I've been researching and looking into is what creates that kind of environment. Because I've been in a number of work environments where I didn't feel it. I didn't feel safe to be honest and authentic, which is one of the key metrics of psychological safety. But interestingly, one of the most important ones was not just honesty about how, like, expressing yourself, but it's honesty about failing. Like, are you comfortable admitting error is the biggest marker of psychological
error or lack of knowledge.
All of this, right?
So
this was Amy Edmondson and Google's Aristotle project. And when they were looking at high functioning teams, psychological safety was the biggest factor in what created high functioning teams. And within that subcategory, it was like, can you admit mistakes? Can you admit to failure? And I think as physicians, we think of illness as failure and death as failure, and we are bound to fail because all humans get ill and all humans die. So we're like literally
Yeah.
set up to fail, but at the same
Yeah.
time we're not supposed to do it. It's such like a horrifying catch-22.
Yeah. Yeah. Well, and let's talk a little bit about people's lived experiences. So, we recognize, I think a lot of us, the way that big T trauma can look in a person afterwards. But I'm thinking more of, the physician who's out there, for example, who, has experienced a lot of little T trauma, and what that can look like. I know for me, when I started to be able to recognize it, there was a situation where somebody in leadership approached me to tell me something that wasn't going well from the left side. I was just at my little desk cubicle, and I had this sudden, it was almost like a panic attack, sort of reaction to being approached on the left for whatever reason. But I noticed that from then on, if somebody approached me from that side, like I had a visceral response.
Yeah.
And I think that can be harder to recognize because nothing in particular that I know of had happened, to sort of give me that response in order for it to make sense to me. But similarly, I have a lot of conversations with physicians who they'll be talking about something. They'll be talking about charting or like a patient complaint or some difficult component of work. And they tell me that, they suddenly have that freeze, sort of panic response. And without knowing that is trauma in their body, they think something is, terribly wrong with them. Like they're not good enough. There's something broken about them.
Well, there's so many things that you've named there, Megan. Part of it is like that psychological wound of shame, not being good enough. And so much of that does stem in childhood, but we also have a lot of that within our medical education and, staff. Like you said, I don't know the answer. Oh my God, the shame. Like, I don't know what's wrong with your undifferentiated symptoms. It's very confusing. I don't know what to do with long COVID. Nobody's told me yet.
Right.
Like the core of shame is so intense. And for me, it just constantly drives my desire to keep learning more because I'm like insatiably curious and I've got all this time that I love learning. It's my passion. And there's also probably a part of me that's driven by this fear of not knowing stuff.
Yeah.
Okay. Like I spent 16 years learning extra internal medicine. I studied Ayurvedic medicine. Okay. What's left? Okay. Lifestyle boards. I'm going to do lifestyle boards this year.
Right.
So it's like a constant journey. And I know that a part of it is curiosity and a part of it is fear. And I have to acknowledge these parts because there is some shame that's welling up. It's built into the system.
Yeah.
The other word that you used was visceral. And I think we're so quick to suppress these interoceptive signals of what's happening inside our body because we're not supposed to have needs of like hunger or thirst or bathroom or whatever. But we get really good at shoving down all of those interoceptive signals. And that's where our emotions come from. Like our emotions are perceptions of our physical cues that are being signaled into the brain and perceived based on our interpretation of context and all these other factors. Like emotions are made and we learn to suppress them. So when they do bubble up and they break through that barrier, sometimes it can be pretty darn overwhelming. Like it'll break through all at once, or it'll be like, oh, I don't know what to do with this. And that was how I felt. Like I've always been a pretty emotional person. And sometimes the emotions would just express themselves quite quickly because they were just leaping out.
Yeah.
And it wasn't until, I'm on the journey. Let's not say I'm at the destination.
We are all on the journey.
Yeah. but I have better emotional regulation skills
Yeah.
and better ability to like just let things flow through and not get caught up
Yeah.
and kind of like a sticky spider web around me where I'm feeling constrained within the emotion. I don't even know what to do with it. So
Yeah.
there's so many different ways that I process. And one of my saving graces in my trauma practice is I do so much somatic therapy that I'm actually teaching patients these skills. So, one thing I forgot to mention is that I'm on social media. So, I'm currently on TikTok mostly as TikTok Trauma Doc, but I will be
Mhm.
pivoting to YouTube and Instagram because we don't really know what's happening with TikTok, even though,
Yeah.
oh
It's
gosh,
fair.
I love it. So, I do a lot of social media education, especially for younger folks. And
Mm.
I use quite different language there, but um, so much of it is just like teaching them like notice what's happening in your body, like notice what happens when your body is overactive
Mhm.
or sympathetic state or
Mhm.
underactive towards an overwhelm of the parasympathetic, and
Yeah.
like what does it look like for you to be in that window. And so many physicians, we either operate in like fight and flight or we operate dissociated, and so few of us can actually maintain that window. And I know when I'm teaching my patients things like havening, which is really gentle self-soothing, that causes delta and theta waves, I'll finish a session having mirrored havening with them, and I'll feel really good at the end of the session, even if the content was a bit intense. Like
Yeah.
with tapping, like there's so many different
Yeah.
things that I'll do with a patient, and I'll feel really good at the end of the day. And I know
With
so
you
much of that allowed
receiving.
my own nervous system to regulate.
Yeah.
I never used to do. I mean, I didn't know how,
Yeah.
but yeah. So what I'm trying to let people know is there are so many ways to do this. I mean,
Yeah.
simple DBT skill of just splashing water on your face. Like
Mhm.
that's such a simple thing to do. Regulating your breath. You don't have to do all of these actual therapeutic modalities, but I put them in the modern trauma toolkit because they're just so easy to learn. I have like little
Yeah.
20-minute videos on the QR code. So easy to learn, easy to, for us to do ourselves, and
Yeah.
super easy to teach a patient in 40, 60 seconds. I can
Yeah.
teach these things.
Yeah.
So I I just think we really need these skills. I wish we could revamp medical education so that trauma was a bigger focus and we actually got some skills on how to manage it because everyone's manifesting it, including us.
Mhm. Well, I love what you invite people to do there, which is, learn some of these tools, right? So that you can use them with patients, but also you get, I don't know, kind of, secondary vicarious, sort of healing yourself and regulation in your own body, going back to that co-regulation idea, right? Where, if we're sort of very activated in that sympathetic nervous system mode, but we're incorporating these tools, into the situation, of taking care of patients, like we get to benefit there, even if, we won't make time for it, in our own lives, right? Because that's a
Yeah,
struggle for people, like we all know that
absolutely.
meditation is a good idea. We all know that, yoga and, some of these other therapies are a good idea. But here is a way where you're sort of, I don't know, invited to practice it throughout your day in a way that helps someone else. It seems like just such a perfect invitation
Yeah.
to start your own practice in healing, even if you're doing it for the good of somebody else, which for my people pleasers in the audience, is often an entry point into being able to get some healing for themselves, right? If I can recognize that something there is going to be good for someone else,
Yeah.
I'm better able to engage with it now and get the benefit of it in addition to helping the other human.
And Kristen Neff's research shows that we are so much more prone towards compassion than self-compassion. So
Yeah.
even if we just start with compassion and say it's better for patient care if you
Mhm.
develop a toolkit for managing trauma responses, and then the secondary benefit is it helps you too.
Oh, I get better
Um,
too.
yeah. So I mean,
Yeah.
maybe that's your doorway. It would be
Yeah.
nice if we all practice self-compassion, but we're not innately taught to do it, and
Nope.
that's a whole other skill set that
But yeah.
I'll leave Kristen to, but I'm a huge fan.
Yeah.
I just did
Well,
one
and
a couple of months back in Sedona, like Chris Germer was leading it, and it was, it's really powerful. And
yeah.
again, there are practices, there are resources. These are skills that we can and should learn.
Yes.
And I know it feels never ending, but um, it, it's to the betterment. Like I would rather know about this than, um, some esoteric thing that I probably never saw as a generalist. That
Right.
this was such a practical daily
Right.
tool. And I
Right.
mean, obviously more so for me now. You
Yeah.
also, I'm just going to pull the thread on one other thing you said about
Yeah.
like that vicarious thing. There's such a thing as vicarious resilience. So when another person is healing in front of you, you also get the benefit of that
Mhm.
um, that healing process as much as we would suffer from vicarious trauma. So I notice now that I have the skills to manage this, whereas before I felt really powerless.
Mhm.
Now I get a lot more of that vicarious resilience. And um, one of the illustrations in the Modern Trauma Toolkit that I really wanted to try to use a metaphor that's the language of our subconscious was the difference between resilience and post-traumatic growth. And so often in medicine, we're taught that the goal is to get people back to their baseline. And that's resilience, getting back to your baseline after a challenge or an illness experience. But post-traumatic growth is, let's use my metaphor. You're floating along, the challenge kind of pulls you underwater, you're drowning. Resilience is you've got a flotation device and you can keep your head up again. And post traumatic growth is learning how to swim. So, like, learning how things could be different. So, I always feel like if I'm teaching my patients skills on nervous system regulation and neuroplasticity, they're going to come out on the other side of it a different person.
Yeah.
And that's what I witness. It's really remarkable. They'll have spent decades, oftentimes locked in complex trauma responses. They learn these skills. Their, foundational beliefs can change. We can do that with therapy now. It's amazing. And they're swimming. They're going from survival mode to actual thriving. And
And
I
if
think so
if
many.
anyone is, watching this on
Oh, dude,
YouTube, here is the illustration from the book,
yeah,
that is showing us, right, this state where we go from being underwater in the experience of our trauma to over here, this post-traumatic growth, right? It's not just getting our head above water, it's actually sort of moving above and beyond. I was like, "I know I saw that picture in here."
wow, that was amazing. And the QR code goes to a hidden website of moderntrauma.com, and there's colored illustrations that you can download and
Okay.
use, put it in a presentation. I really wanted to share these images that were soft
Yeah.
and person-centered. So just try to illustrate these things in new ways.
Yeah.
Uh, yeah, and I think so many physicians were in survival mode, and that's why I really closely link burnout to trauma. Like I would
Yeah.
hesitate to say that there's anybody who's experienced burnout who hasn't got some trauma responses stuck in their body.
Yeah. Yeah.
And we just haven't named it yet. So I'm
Yeah.
I'm
And
excited
we
to have
live from the
it.
head up, right? And so we're often so disconnected from our bodies that, it's even hard for people to name what are the sensations. Like if you ask somebody, what is the emotion and where is it in your body? What? What? I don't know. I don't know. What are you talking about? Right. Um, so this is such a lovely opportunity for people to, in safety, start to reconnect, right? Start to reconnect to the physical body and yeah, and just have an opportunity to learn.
Yeah.
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 And
And part of what I did on TikTok was just share these tools,
mhm,
super accessible, like 1-minute videos. So I would teach skills like tapping, havening, um, like some eye movements related to brain spotting or art. Like
yeah,
I do accelerated resolution therapy for process. I can't do that on TikTok, but I can show you how the eye movements work.
yeah,
I can run you through interactive guided imagery.
yeah,
I even did some longer videos showing people how to tremor, which is the same way a dog or a horse would shake off their sympathetic
mhm,
tone and like that extra muscle tension. Humans are actually supposed to do that. And some of us do it. I remember doing it after an MBA, like a really long time ago, almost 2 decades now. And I remember that sensation of tremoring after, I almost died.
yeah,
But I didn't realize that that was something that our bodies were innately designed to do until I learned it's called TRE, or trauma releasing exercises.
Mhm.
Human bodies are totally capable of tremoring.
Totally
And
do this. Yeah.
yeah,
Yeah.
so I put that as like longer videos totally for free on my TikTok under a folder called Healing Skills.
Okay.
But I'm just trying to get the word out. I mean, if we
Yeah.
taught this stuff to school children and teachers, dentists and lawyers, physicians and nurses, we wouldn't be so burned out. We wouldn't be suffering and, carrying the suffering of others with us.
Yes. I think that's so true. And I'll have you speak to one more thing that's in the book, which is this theory of spooning, which I thought was just such a lovely visual for people who are, currently experiencing, burnout trauma and not really realizing sort of why things feel so hard for them right now. Could you share that story with us?
Yeah, I'd love to. Um, so spoon theory was created by a woman who had lupus, and she was trying to explain to a friend like what it meant for her to need to pace and to watch her energy levels because she just didn't have the capacity. So kind of sharing what an invisible illness is like to say, and so she used spoons because they were in a restaurant, and she just grabbed spoons off the table and said, okay, well, if you're starting your day with this many, I'm starting my day with half as many spoons. And I have to be really careful where I might spend a whole spoon. So if I did something like cook dinner, there's no way I would be half another spoon to wash up after. So that helped her friend realize. But it's the same analogy as a battery or a gas tank. And I
Hmm.
think trauma does it, certainly because our amygdalas take a lot of energy to be constantly sending us danger signals. So a lot of us spend our whole work life in that amygdala fight and flight tone. Um, but even just that that sense of burnout and exhaustion is so
Yeah.
often like manifesting every single day, and you starting your day with a half a tank of gas or a quarter
Yeah.
tank of gas,
Yeah.
and you're trying to do all the usual things and you're wondering, well, why can't I do it? And then the shame increases.
Right.
Well, you didn't even have a full tank of gas when you woke up this morning, and it had nothing to do with how much you slept. It's just that somebody's been siphoning off your tank,
Right. And it hasn't been getting filled up.
been insurers, and you don't even know how to fill it back up. And
Yeah.
that's another thing that I really wanted to do in the modern trauma toolkit. And a lot of other trauma folks say it like it is yoga, it is time in nature, it is having a pet. Like it is so many things that are within our ancestral lineage. Our
Hmm.
ancestors used to do regular rituals of circle dancing and chanting. Okay, well, circle dancing is releasing your sympathetic tone, and chanting is enhancing your parasympathetic system through a longer exhale and vibrating your vagus nerve because of your lung pleura. That tracks. Now we understand the physiology behind all these rituals that we used to do, but we've been socially conditioned to forget.
Yeah.
I'm in a physician conference this week, and there's these women physicians who created a choir, and they will talk endlessly about the joy that this choir brings them. And I honestly believe it's community, but there's
Hmm.
also all these somatic factors because
Hmm.
we were actually designed for this. And we've
Yeah.
historically, throughout our lineage, almost every cultural background had these kinds of rituals that we've just lost.
Yeah.
So a large part of what I wanted to focus on is like, what did we forget that we kind of innately knew? Because you mentioned prazosin at the top of the hour. I mean, let's be honest. You can take metoprolol for your daytime anxiety and prazosin to suppress your daytime nightmares, but all you're doing is, changing your vital signs
Yeah.
because they are a manifestation. So you're treating a very superficial symptom
Yeah.
when the root cause is like what is happening deeper
Yeah.
in your nervous system. And there are so many ways to shift it.
Yeah.
I don't know how we don't all know this. I mean, it was
It's a
such
masking instead of a digesting, instead of a healing.
oh yeah,
Right. Let's
exactly.
just mask these symptoms with this, and you'll appear to be doing better.
Well, and it's like you have this festering wound of your burnout and your distress, and you're just putting a bandage on top of it without like actually treating the wound. And there are so many joyful ways to do that. And
Yeah.
I just I love sharing it.
Yeah. I have a feeling that we could really talk for 3 to 4 hours as we suspected, early on. But for somebody who's out there listening to us talk and listening to some of these things that you're mentioning and recognizing in themselves, "Oh, I realize the impact that, that medicine is having on me." They're just kind of realizing, kind of how this might be trauma. Like, what do you think would be most helpful for them to know? And of course, speak from your own experience as well of having experienced burnout and, as a human, just, having lived through some traumas.
Yeah, I didn't even get into like I was in the earthquakes in Nepal in 2015. So I had a lot of post-traumatic like stress symptoms. I didn't have full PTSD from that, but I did have a lot of symptoms. And it was amazing because when I trained in the havening techniques,
Mm,
during the training session, I actually decoupled all of the triggering associations from that memory in one
mm,
single session.
mm,
So I think my biggest like um just point of hope is that there are so many effective modalities. And interestingly, when they do the research on all of the different alphabet soup of therapies, most of them are quite equally efficacious. But
mm,
for me, a really sound doorway is the body. Because when your thinking brain isn't working because your amygdalas are so busy, it makes sense that the more accessible and amenable doorway is going to be the body. So learn some somatic techniques, and whether or not that's breath, that's something that a lot of us are, feeling more attuned with, but there
mhm.
are so many other quick and easy things to learn. So just build your personal and professional toolkit so that you feel competent and a sense of hope instead of a sense of dread. Because
Right.
sometimes when patients with complex trauma show up, I mean, they are the ones who have all kinds of chronic illness because one begets the other. That's what
Yeah.
the ACEs study showed. Um, we can feel really hopeless and we can give that sense of giving up to the patient. So it's so much more generative and emergent for us to have that hope within ourselves. And
Mhm.
it's super possible. You don't have to spend 8 years studying the stuff like I did. You could learn some of these things on a weekend. You
Yeah.
could pick up the Modern Trauma Toolkit.
Yep.
This stuff exists and it's well within our capacity in any realm within medicine to manage it both within ourselves and others.
Yeah. So that is an invitation for everyone listening to go buy the Modern Trauma Toolkit, as seen here, and we'll put links, of course, for that, and to really follow Christy so that you can start to pick up some of these things. Because while we are often inclined to go and learn, 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 and I have to learn all the things, I have to get a certificate, I have to do a deep dive study before no. What we're saying is that you can learn one or two little skills, right? And
Yeah.
start to practice that in real time with real humans, as a way, as an entry point, not only for helping them to get some healing in whatever's going on with them and helping to decrease their distress when they come in for medical care, but also to benefit you, right? To start you on somatic practices. I think it's such a wonderful resource to have it all, kind of bundled into this very practical, very approachable source. So I'm so glad that you could come and talk to us today and share a little bit about like why we need even a little bit of skill around this. It's been such a wonderful conversation.
It has. Yeah. I was saying earlier, it's just so nice to speak to somebody who already has this language in their lexicon because so much of us are saying, oh, well, trauma. It's just everyone's using that word. It's totally overused.
Everyone's traumatized.
No, we're not actually defining it often enough. We don't recognize so much of medical practice as traumatic,
Yeah.
inherently traumatic, and we don't recognize trauma responses in our patients a lot of the time. So let's use it more.
Yeah. Yeah. Let's see. So we've mentioned the book, which is called The Modern Trauma Toolkit, and you shared that you're on TikTok at TikTok Trauma Doc, although perhaps moving to other platforms based on whatever happens with TikTok. Where else can people find you to learn more and work with you?
Yeah, my other spaces, I just go by Christy Gibson, MD. I think on Facebook, I'm Christine Gibson, MD, which was really exciting. I guess it's Mental Health Month, but I got uh, quoted in both Time magazine and the Mirror UK about like Prince Harry is using tapping, and so they were wanting to learn more about tapping, and there's not a lot of physicians who do it.
Yeah.
So
Yeah.
it's been actually really great to be sharing these resources and just knowing this interest is out there. I run a company around psychological safety in the workplace, which includes trauma-informed spaces, psychological first aid. What do we do when somebody's having a meltdown, which many Gen Z are not afraid to have?
Yeah.
This is one of the reasons I joined TikTok, is because they are unabashed in actually having emotions.
Yes.
And, older generations, we were just taught to suppress.
Yeah.
Um, so I think that's really crucial. Safer communication strategies. So that company is called Safer Spaces Training, which is just saferspacestraining.com. The book is moderntrauma.com. And I love to do keynote talks and workshops. If anyone wants to learn these skills in real time, I'll come in for a half-day workshop to your space. I'd love to do that. So that's just christinegibson.net.
Great.
Christine with a CH. So lots of ways to find me. I don't take patients. What I'm trying really hard to do is more social innovation and systems entrepreneurship. So I've also got a certificate in design thinking and social innovation. I've even mentioned how to do that in the book. So part of what hurts us is that these traumas continue to happen to people and to ourselves within the healthcare system.
Mhm.
And we are not trying to create ableist environments. We're not trying to cause medical trauma, but we inadvertently do. And so much of what needs to change is changing, like redesigning health systems in more trauma-informed ways. So I just want to be part of that discourse and these transitions, because current health systems are not working. They're kind of blowing up and imploding all across the planet. So as we redesign them, wouldn't it be nice if it wasn't so traumatic on ourselves and others?
Yeah. Oh, yes. That's all I can say is yes. Um, it's such important work, and it really has to happen on all levels, right? We need healing as individuals. We need healing and kind of patient relationships and patient cares. We need healings in our the buildings in which we work and
Mm.
operate, but also across all of healthcare, in our identities as helping humans. Thank you so much, not only for being here and sharing this with us, but also for the work that you're doing and just the continued passion to really help heal this component of healthcare, which is again really just under talked about and so important.
Well, it's been a real pleasure to chat with you about it. And I look forward to collaborations. I think the more of us that are speaking about this and doing something about it and helping change these one-on-one relationships, which you're doing so vividly, I think the systems will change.
Yeah.
So we have to name it first.
Yes. Yes. Well, thank you as always for listening, everybody who's out there. And please go follow Christy, get her book, learn some practices for yourself, and join us on this journey of starting to heal, the very real hurts that are out there in our patients and out there in ourselves. Until next week, have a great time. Bye-bye.